All right, so I just want to give you all a little idea of who Dr. Timothy Daniel is. He earned his undergrad degree from Brooklyn College. He obtained his PhD in organic chemistry from the University of Texas at Austin. Dr. Daniel attended Harvard Medical School and completed his residency at the Baylor College of Medicine with a focus on internal medicine. He is an advisory board member for the Abbott Diabetes Care and Bena. And when he's not working, he enjoys jogging, reading, watching sporting events, traveling, and listening to music. He has two sons. I met one of them because Carl Roberts, my hon, is his buddy. So that's how we brought the connection together. I need to let you all know that he practices in Pearl Land, Texas. Okay, and that office number is 346-646-3481. Good morning, Dr. Timothy Daniel.
Morning, Lima. Morning,
You see,
morning,
now you're
and thanks
calling me
for the
Lima. Why you doing me that, man?
Sorry.
Apology so accepted. Apology accepted. So the last time you were here, you were able to tell us the difference between type 1 and type 2 diabetes. But you know, in doing some reading a couple days ago, I realized that there's gestational diabetes. We don't really talk about that, right?
Yeah,
Why you
yeah.
think we don't talk about that much?
Because gestational diabetes occurs, of course, during pregnancy. Okay, and of course, for most patients, it resolves after pregnancy. Now, on the other end, patients with gestational diabetes, they are at increased risk of developing diabetes later on in life. And
Oh,
so I think most of it is because, of course, once the patient deliver her baby, then, of course, the diabetes tend to resolve. So no one really matters too much
it
about
goes
it
away.
after that. Yeah,
But
yeah.
you know, I felt I don't I have to ask this question because this show is not just about information; it's all about black empowerment too. Do you still is there a correlation between gestational diabetes and the black us as black people, or does it
Um,
show up more in black
I, I,
females as opposed to?
I'm not sure if there is an ethnic predisposition for gestational diabetes. Of course, maybe there could be a possibility because, of course, there is a relationship between ethnicity and diabetes. So, what we recognize is that people of African descent, people of Latino descent, they actually have a higher predisposition for diabetes. So, I'm sure that possible
There
there
could
might
be a
be a
correlation or okay predisposition.
predispositions. Yeah.
So, are there any updates from the HHS that would impact the standard of care for your patients? Because I know they came out with one in January of 2025.
You're talking about the ADA. Is it the ADA, the American Diabetes
Yes,
Association?
yes, yes.
Yeah,
They do
yeah.
that every year?
Yeah, every year the standard of care they publish. In fact, I actually keep those in my uh, exam room. In fact, I have the 25, the 24, the 23, and the 22 in different exam room because it's
um,
good to show patients exactly what the book says and it's not what I am saying.
I,
So
I'm I'm laughing because when you say that, I'm thinking of back in college where they would have a book, and then the following year they want to
yeah,
change the book, and it's just
I
one
mean,
page that would make the difference.
well, no, actually, so it's a little bit more than that because I sometimes show patients the comparison. The 2017 standard of care is about half the size of the 2025, literally. And that's because we have a lot more information right now. I mean, even, we're talking about the different types of diabetes, right? So if you go back about 5 years ago, so for the diagnostic criterion for type 1 diabetes has actually changed. Well, if you go back 15 years ago, we did not know the two difference, right? between type 1 and type 2. 15, 20 years ago, we based type 1 and type 2 on age. Okay? Yeah, 15, 20 years ago, if you develop diabetes as a kid or teenager, we call it 1. If you're adult, we call it 2. Now, in the last 10, 12 years, we now have diagnostic criterion for type 1 diabetes and type 2, which is actually based on blood tests. And then in the last 4 years or 5 years, we actually have different stages of type 1 diabetes. And so the information actually changed more than just a page. So, you know, and if we think some new information in the last standard of care, one of which is the impact of weight. So if I look at the 2017 standard of care, they used to say, for example, losing weight may help, whereas in 2021 they say it's highly beneficial to treating type 2 diabetes. So I think we have a lot more information, even things like measuring blood glucose, right? We did not have continuous glucose monitor. In fact, I actually have one on right now.
Okay.
So yeah, so you know, 10 years ago, we did not, that was not in the standard of care.
So that monitor that you have on, is that something that you would recommend for people like that are pre-diabetic or just or anybody in general?
Sure, exactly. I am pre-diabetic myself, so that's why I have it on. And I'm doing a Lenten fast, so I want to see what impact my Lenten fast have on my blood sugar. Okay. Yes. In fact, it's highly recommended for anyone pre-diabetic, diabetes. So the continuous glucose monitor, they actually have two main companies that make them. Well, they're actually three, but one don't really sell too much for other people because they use it with their insulin pump. But we have Freestyle Libre, which is made by Abbott, and then we have Dexcom. Okay? So those are the two main continuous glucose monitoring system that we have. Now, of course, I could go on to talk a lot about that, but what I want patients to know particular is that those continuous glucose monitor, they don't actually measure blood sugar, but that's the fundamental thing that we need to understand.
Okay.
They measure what they call the interstitial fluid sugar, which is the blood glucose under your skin. Now that equilibrates with your blood sugar over time, but sometimes they're not on the same page. And sometimes patients say, well, you know, I prick my fingers, it's not the same as the continuous glucose monitor. And of course, they're not the same because they don't measure the same thing. And they may not be on the same page at the same time. Now, overall, they will be this. Pretty much the overall average will be the same.
So you would recommend both at the same time, pricking the finger as well as the monitor, or which one would you say, okay, first dibs on?
Well, okay, so why are we measuring? That's the first thing, right? I think we measuring blood sugar first, of course, to know where you are, but you also want to measure to make a difference, to change things. And that's where the continuous glucose monitor comes in for me.
Okay, so I guess I'm putting it out there, which I don't normally do. I am pre-diabetic, so maybe I need to wear a glucose monitor.
Yes, yeah, because, for example, if you want to truly measure your blood sugar, even if you're pricking your finger, what I would actually recommend is that you vary the time when you measure your sugar. So you want to measure your sugar occasionally before you eat, but you also want to measure it 2 hours, 1 to 2 hours after you eat.
Okay.
So you can see what's causing your blood sugar to go up. Okay. For example, before you eat, your blood sugar should be between, if you have diabetes, should be between 80 and 130. Okay, that's the recommendation in the ADA guidelines. So 80 to 130 before you eat. But 1 to 2 hours after you eat, if you have diabetes, it should be less than 180. Now, if you're not pre-diabetic or diabetes, 1 to 2 hours after you eat, it should be less than 140. So normal people, blood glucose is never more than 140 after they eat.
Normal people.
Okay. Now,
I used to be
well,
that. Okay.
yeah, I mean, you're not pre-diabetic or you're not or you don't have diabetes. It
I
should not be
if
more than 140 after you eat.
140.
Yeah.
Okay.
Yeah. Now, on the other hand, before you eat fasting, if you don't have pre-diabetes, your blood glucose when you wake up in the morning should not be above 100.
Should not be above 100.
Yeah. So between 100 and 126, if you've never been diagnosed with diabetes, that's usually pre-diabetes. Now, if you're typically more than 126 when you wake up in the morning, then that's diabetes.
Wow. Wow.
Yeah.
So is that monitor something you have to wear all the time, or you wear it for a certain amount of time and then you take it off?
Okay, so the continuous glucose monitor. So I was going to say we have two main types, right? We have Dexcom and Freestyle Libre. Medtronic, which is the Guardian, they use it with the pumps. Very rare they promote it as self by itself without an insulin pump because they sell them jointly. But the Dexcom and the Libre, it's an individual stuff that you can wear. They have the personal one. What I recommend for if you have diabetes and you're on insulin, for example, the Dexcom and the Libre both have an alarm system, okay? And so they're able to tell patients, if the sugar is above 250, it's going to alarm you. If it's under 70, it's going to alarm you. And you can set the targets when you want it to alarm.
Okay.
Both of those now have not over the counter, but because you have to go online, and they have an online form of those, both the Dexcom and the Libre. So we have now one called Stelo, and that's a Dexcom where you can go online and order it from Stelo.com.
Okay.
And that one is for pre-diabetes and type 2 diabetes, not on insulin.
Not on insulin. Okay.
Because, of course, if you're on insulin, you want the alarm. They don't have an alarm. So they don't, buzz you if your sugar is too high or too low. Because if you're not diabetic, you probably would not have an alarm at 250 or something. So because your blood glucose would probably not get above 250. So that's for the Dexcom. There is Stelo.com. You can go and buy this one. And then Freestyle Libre has one also called Lingo.com. Or Lingo is the actual monitor, but you can go to Lingo.com and buy that. So those are for people, pre-diabetic or diabetes, not on insulin. The Dexcom and the Libre has to be obtained via prescription.
Okay.
The Stelo and Lingo, you don't need prescription. You just
go online and get
it.
I have one more question.
Sure.
Because again, it's a tight show. I'm sorry.
That's okay.
Metformin, which is a drug that's taken for pre-diabetes and diabetes, I believe,
and
right?
Gestational.
And gestational. They're saying that it's no longer a preferred medication for diabetes. Is it the cost? What is it that is saying
You said it's not preferred?
It's no longer a preferred.
That's okay. So it's not that it's not preferred. What it is that we have other medicines these days that have so many other benefits. Okay, so like the standard of care up to 2021, metformin was still the first line for type 2 diabetes. Okay, however, we now have medications called the SGLT2, like Jardiance and Farxiga. We have the GLP-1s like the Ozempic, the Trulicity, and now we have GLP-GIP like Mounjaro. So those other medications, the SGLT2, GLP-1, they have actually shown to reduce heart attacks and strokes. Some of them reduce hospitalization from heart failure.
So they're actually attacking other things other than the diabetes.
Other than the diabetes. In fact, they are prescribed by cardiologists. They are prescribed by nephrologists. So Farxiga, for example, which is an SGLT2, actually has been approved to treat chronic kidney disease.
Okay.
And then Ozempic just got indication to treat kidney disease also. So
Okay.
we have all these other benefits. So that's why they're now saying in the standard of care, when you look at 2022 standard of care, there's a section said that if you have these risk factors, if you have heart disease, if you have chronic kidney disease, if you have heart failure, these medicines are now first line
Okay.
because it treats those things in addition to your diabetes. So
Okay.
I think that's where the standard of care is. Not that metformin is still, of course, if you don't have none of those issues and you just have some, little diabetes, type 2 diabetes, then of course metformin will be, because it's of course not as costly. In fact, you can get metformin without insurance for about $4. Of course, the other medicines without insurance will be $1,000 a month. So I think that's where the
That was coming
difference is.
from.
Yeah, it's not that it's not still not in the standard of care, or
Okay.
if it's not first line, but it's because other medications have preferred benefits,
Okay.
and so they know, yeah,
So,
first
so,
line.
so, Dr. Daniel, can we look forward to having you back in about 3 to 4 months?
No problem. Anytime, anytime. I'm truly dedicated to doing as much as I can to help folks with diabetes.
I
And
appreciate you.
yeah, and anytime I'll be really open to being
By the way,
back.
Carl said hi. I know he's listening, but he said hi. And
Uh,
if you live in Texas, it's 11619 Shadow Creek Parkway, Suite 110, Pearl Land, Texas 77584. And the phone number for the office is 346-646-3481. And then you can always listen to the People's Chat Room when you know he's coming on. And we encourage people to share or post questions, but this time around, we didn't have a whole lot, just me finding the right information or finding questions that I felt was pertinent to what I'm going through, because I really think I need to get the monitor. So,
Yeah, it's actually really helped because what that way you can see what caused your blood glucose to go
to
up,
go up.
and you can make the changes. I mean, you can look at literally. It takes most of them take a blood glucose reading every minute and saves it every 5 minutes for you, so you can see the graph, see when it goes up, see what caused it to go up, and then just make the necessary changes to keep your blood glucose under control.
Thank you so much.
You're
All
welcome.
right.
You're
And tell
welcome.
Tia I
Yeah.
said hi, and I'm sure that's coming from Carl also. And you have a blessed weekend.
Okay, thank you so much. And you
Thank you.
guys do the same.
Thank you
Say
so
hello to
much.
Carl.
I
Yes.
will.
Okay.
Thank you.
Okay. Bye.
Dr. Timothy Daniel, our diabetologist. Please share the information. It's embedded in the show. We are also on YouTube where the shows are archived. So if you missed it, you can go back and hear it. And for I think at least the next couple of weeks, you can go back to the Facebook posts.